trying to keep these lectures to 15 minutes or less, but sometimes with the pathologies I go over a little, over to 20. So here we go. Lower motor neuron pathologies. So the learning objectives, there's some crossover between the terminology of lower motor neuron and upper motor neuron. And so we'll talk about it in here and then we'll talk about it again in chapter 14. So repetition is good, it helps you learn it. So we're going to talk about involuntary muscle contractions and different pathological um, involuntary muscle contractions. The definitions that you need to know are clonus, atrophy, fasciculations, fractionation, hyperreflexia, hypertonia, spasticity. Paresis and paralysis, what are they and what's the difference? Signs and symptoms you would expect to see if a lower motor neuron was destroyed and the muscle was completely denervated. Hypotonia and flaccidity, which are low muscle tone conditions, and the symptoms of post-polio syndrome, which is a lower motor neuron problem. So involuntary muscle contractions, they happen to us all. So they can occur in a healthy neuromuscular system, or it might be a sign of pathology. So muscle cramps, who hasn't had a cramp? We've all had cramps, and there are a million things that cause them. But by definition, it's a severe painful muscle contraction lasting seconds to minutes. Fasciculations are quick twitches of all muscle fibers in a single motor unit. And myoclonus is a brief involuntary contraction of a muscle or group of muscles. So it's just like muscle contraction. Um, those types, so muscle cramps, fasciculations, and myoclonus are they can occur in a healthy neuromuscular system, or they might be a sign of pathology. But abnormal movements generated by dysfunctional basal ganglia, and we'll talk about that in chapter 16, fibrillations and tremors are always pathologic. So muscle cramps, fasciculations, and myoclonus can be either, but abnormal basal ganglia movements, fibrillations, and tremors are always pathological. So fibrillations are random, spontaneous, brief contractions of a single muscle that are not visible on the surface of the skin. They're always pathological. So it occurs when a muscle membrane is unstable because of denervation, trauma, or electrolyte imbalance. You cannot detect a fibrillation by seeing it. Like with fasciculation, you could see it and feel it. With a fibrillation, it's only detectable by electromyogram. We'll talk about the process of an electromyogram a little bit later. So they're always pathologic. They're only detectable by EMG. Tremors are involuntary rhythmic movements of a body part, and they're classified as either resting tremors or action tremors. Physiological tremors can be enhanced by anxiety, stress, fatigue, medications, metabolic disorders, caffeine, or alcohol withdrawal. Or if you do too many push-ups, that's fatigue. That's But resting tremors, if you ever done that, like you go to boot camp class and you do too many push-ups and then you're like pick up glass and your hand is trembling. So yeah, those could be a tremor. So a resting tremor is most visible when the person is not intentionally moving. So they're just sitting there and they have a tremor. Postural tremors occur when a body part is maintained against gravity. So if you're holding out your hand like, hey, hand me those keys, and you get that postural tremor. In Parkinson's disease, the tremor is typically a resting tremor affecting the hands and the lower limbs. Restless leg syndrome is really common in people with Parkinson's. Cerebellar tremors are usually intention tremors, and they're most severe during the final part of the movement. Psychogenic tremors are characterized by sudden onset and sudden remission. So, a tremor is just one piece of the picture. It's not going to be diagnostic of any particular thing, but it can be classified as resting or action. So there are three types of action tremors: postural, orthostatic, and intention. Essential tremor is the most common pathological action tremor, and it's idiopathic. They don't know what causes it. Kind of a drag. Um, If lower motor neuron bodies or axons are destroyed, the affected muscles are denervated, and so they have a loss or decrease of reflexes, paresis or paralysis, and well, paresis is muscle weakness, and paralysis is complete loss of muscle strength. Um, Atrophy, where the muscle loses size, decrease or loss of muscle tone, and fibrillations, which we said were only detectable by an EMG. So if you're having some of those other things, they might do an EMG to confirm and detect those fibrillations. Um, because the lower motor neuron is the only route from the spinal cord to the muscle, lower motor neurons interrupt the efferent limb, the efferent part of the reflex, efferent limb of the reflex, if you want to think of it that way. So remember, we said the reflex had the sensory part, the afferent part, then it went to the spinal cord, and then it had the efferent part. So the lower motor neuron is the part that is causing the decrease or loss of reflexes. So you can feel the sensory part, but then the motor part doesn't work. So that's why you have the diminished reflex. Paresis and paralysis are loss of or decreased ability to generate muscle force, as it's a common consequence of lower motor neuron lesions. So complete lesion of a peripheral nerve produces paralysis where you have no movement, because lower motor neurons are the only pathway from the central nervous system to the skeletal muscle. If you have an incomplete lesion, then you can get paresis, which is decreased ability to generate muscle force. So if you want to think about, paralysis is complete loss of movement and paresis is partial loss of movement. Muscle atrophy is loss of muscle bulk. So disuse atrophy results from lack of muscle use, and you can get that from anything. Neurogenic atrophy is caused by damage to the nervous system. So complete denervation of skeletal muscle produces severe muscle atrophy because frequent neural stimulation, even at a level inadequate to produce muscle contraction, is essential for the health of skeletal muscle. So we have that background activation that's always going on. And when you have muscle denervation, you lose that and it results in atrophy. Abnormal muscle tone, um, usually lower motor neurons cause abnormally low muscle tone or total lack of muscle tone. So hypotonia is abnormally low muscular resistance to passive stretch. So muscles are more elastic than normal. And flaccidity is total lack of muscle tone. So if you have um, a complete lower motor neuron lesion, the muscle will be flaccid. It will have zero tone in it. And once you feel what a flaccid muscle feels like, you'll know. So, two different types of electrodiagnostic studies are performed on lower motor neurons: nerve conduction studies and EMGs. And we talked about nerve conduction studies with regard to sensory nerves. You can also do it on a motor nerve. Um, the nerve conduction studies are usually used to differentiate among three possible sites of dysfunction: either the nerve, or the neuromuscular junction, or the muscle. So they're trying to say, like, what's really going on here? Where is the problem? The skin over the nerve is electrically stimulated, and then the electrical potentials are recorded from the skin overlying an innervated muscle. And then the computer um, generates information about the speed of nerve impulses. If you have fibrillations, it doesn't necessarily show up on a nerve conduction study, but it'll show up in electromyography. So surface EMG, the electrical activity of muscles recorded from the skin overlying the muscle. A diagnostic EMG requires inserting a needle electrode directly into the muscle. And the idea of it is you want to distinguish between denervated muscle, so the surface EMG is checking the nerve, and then actual myopathy, an abnormality or disease intrinsic to the muscle tissue. So the diagnostic EMG, it feels weird. I've actually had it done, and it feels like somebody's poking you, like not with a needle. It doesn't feel like getting an injection. It almost feels like somebody is like snapping a rubber band on you. If you know what that feels like. So the muscle electrical activity is recorded during four conditions: when they insert the needle into the muscle, while it's resting, during a minimal voluntary contraction that elicits single motor unit action potentials, and during a maximal voluntary contraction that generates a full recruitment pattern. Um, so the information that they get is it the nerve? Is it the muscle? Is it the neuromuscular junction? So during rest, um, you might get fibrillation, which is always abnormal, or fasciculation, which could be normal or not. Um, the fasciculation that's normal is caused by dehydration or electrolyte imbalance, or sometimes just being old. It's kind of a drag. The pathological fasciculation occurs when demyelinated neurons develop ectopic foci and cause abnormal action potentials in the axon. So it's like that cross connection, if you want to think of it that way. Trauma, infection like poliomyelitis is caused by the poliovirus. Degenerative or vascular disorders or tumors can all damage lower motor neurons. In some survivors of polio, post-polio syndrome occurs after the acute illness, because even though the innervation to the muscles get re-innervated after the acute illness is gone, but they don't get re-innervated by as many alpha motor neurons as they had before. So the symptoms are usually muscle weakness, joint and muscle pain, fatigue, and potentially breathing problems if that's the muscle, if those muscles are involved. Pain is sometimes caused by overworked muscles and ligament distress due to muscle weakness. Um, there's some theory that post-polio syndrome is a normal age-related strength decline, but it's more obvious in people who previously had polio. All of the people that I've worked with who've had post-polio syndrome were all older people, and they had been kind of dealing with this their whole life. And they had something that set them back, which is why they ended up in PT. So post-polio syndrome is the most common lower motor neuron disease in the US. However, since polio vaccines came out in the 50s, um, it's going to be less and less common because you don't have people with polio. You're not going to have people with post-polio. Exercise recommendations for people with post-polio, if their strength is near normal and there are no signs of reinnervated motor units on EMG testing, then you can do heavy resistance training. If there's moderate weakness or signs of reinnervation in EMG testing, then you do submaximal endurance training, so low weight, high rep. If you have severe paresis, walking, usually with an assistive device, stationary bicycling, swimming is a wonderful exercise. Um, most of the people that I've worked with, since they are older people and they have had it a long time, they kind of know what they're supposed to do and when to rest. That's really nice. And sometimes they just need a little extra help. So one time I worked with someone who they were in PT because their weaker leg, their post-polio affected leg, was fine, but they had an orthopedic issue with the stronger leg, and so they kind of had to compensate. They had to learn how to compensate. And a lot of times that's the case when you're working on balance and gait training and strengthening. So movements of the limbs and trunk rely on spinal lower motor neuron innervation of skeletal muscles. Somatosensory information, signals from networks of spinal neurons, and signals from descending upper motor neurons all converge on lower motor neurons to elicit coordinated muscle contractions. Involuntary muscle contractions include muscle cramps, fasciculations, myoclonus, tremors, fibrillations, and abnormal movements generated by the basal ganglia. The last three of those are always pathological, and the other one, sometimes they are and sometimes they aren't. Complete lesions of lower motor neurons cause flaccid paralysis, severe muscle atrophy, fibrillations, and loss of reflexes. So, complete lesions of lower motor neurons can be very disruptive to your life.